Dr. Janaka, over to you.
Good afternoon to all of you. I am Dr. Janaka Marakon, Vice President of SLVA. I warmly welcome you to the 13th webinar of the SLVA webinar series for 2021, organized by the 73rd Executive Committee. We are encouraged to see the demand for this series, and today we have nearly 500 veterinarians registered for this. Dr. Bhagya has been one of our regular resource persons who has done a great job in the past in bringing in new knowledge to our membership. Now I would like to invite Dr. Erandika Gunawardena, the president of SLVA, to welcome the resource person and the participants.
Yeah, thank you very much, Janaka. Yeah, actually, as you said, Bhagya being a very good resource person for us, even previous years also he joined, and he came over here to do some practical workshops. In fact, we were planning to have a practical workshop with Dr. Bhagya about this orthopedics, advanced surgeries and their techniques, but due to the COVID situation in the country, we compelled to drop those opportunities. But anyway, we are still trying to get the the maximum out of Dr. Bhagya today also. So once again, warmly welcome for our series of webinars who are joining from overseas and local. This our Zoom platform today with us, and some reminders from the association. Actually, we are just at the end of compiling our Your Veterinarian magazine also. So you are welcome to send your articles. Still, we have some few pages. I mean, we can just fill up. And further, we have extended submitting abstracts for our scientific sessions 2021. And still in the animal production section and other sections, you are also welcome to forward your abstracts for the reviewing sessions by the reviewers. And we have one more week. And yeah, with those messages, I would like to again welcome for this important webinar on Patella Luxation correction. So I'll hand over the forum to our secretary to introduce our resource persons today. Thank you very much. Dr. Sugat, over to you.
Thank you very much, Mr. President. Can I hear me?
Yes, we can hear you, Sugat. Yeah.
Thank you. Good afternoon. It's a pleasure to introduce our resource person today. Dr. Bhagya, he passed the BVSc Honors degree 2005 in University of Peradeniya, Sri Lanka, and he obtained national veterinary exam. He passed the national veterinary examination in Australia in 2009, and he is a member of Australia and New Zealand College of Veterinary Scientists, special on surgery, and he worked in few general practices since 2010 to 2017. Currently, he is working as a veterinarian and director of Avenue Animal Clinic Australia, and his special interest on orthopedic and soft tissue surgeries. And he is a well-famous veterinarian in Sri Lanka as well as in Australia also. On behalf of Sri Lanka Veterinary Association, I would like to invite Dr. Bhagya Don to continue the webinar. Thank you.
Thank you, Sugat. Thank you very much for the introduction, and thank you very much, Sri Lanka Veterinary Association, for the this opportunity to do this presentation. You all can hear me okay?
Yeah, we can hear you, Bhagya. Yeah.
Okay, thank you. I'll start the all right. So today I'm going to talk about the patella luxation. which is a very common condition in small animals, particularly. The content that I'm going to talk about is first we'll briefly go through the surgical anatomy and pathophysiology of this particular condition, and how to grade, how to understand different grades of patella luxation and what it means, and easier way to remember it as well. And also how to diagnose, when you diagnose in patella luxation, and what kind of practical things that we can look into. Then the radiograph techniques, and how to take accurate proper radiographs to make a proper diagnosis. And also we'll talk about some factors that help with surgical decision making, when to do surgery, and how to do it, that sort of aspect. And then mainly we'll pay more attention on the medial patella luxation surgical techniques. There are a few going to discuss today, and also briefly post-operative care and complications as well. First, what is patella luxation? The first, it's a condition of the stifle, basically, or quadricep mechanism in correctly. So first we'll look at briefly the anatomy of the stifle. Like the patella. So this little picture on the side shows the simple diagram of a stifle joint, the quadricep muscle, and then patella here, and the patella tendon, and then the tibial tuberosity. So this the whole thing called quadricep apparatus or quadricep mechanism. So the patella luxation means the patella meant to be in the center of the femur, in the distal femur on the trochlea, and it is moving outside of that trochlea, and that condition called patella luxation. So this could move medially as well as laterally. When it luxating medially, it's called medial patella luxation. When it luxating laterally, it's called lateral patella luxation. So these three radiographs I put here. The first one shows the normal patella, which is this is the patella, it's right in the center, and this is an example of a medial patella luxation where this is the fibula, so that's the lateral side, and then the patella is in more of a medial position, that's a medial patella luxation. And this is a lateral patella luxation where the patella is on the more of a lateral position. So how common this condition is? A very common condition in puppies. In various studies shows different figures. Generally, it's 1.5 to 7% roughly common in all puppies. So it's very, very common. And out of these two types, medial patella luxation and lateral patella luxation, medial patella luxation is the most common thing. It in small breeds, it's almost all the time happens medially, so pretty much like 98%. Even in medium to large breed dogs, that's the most common type, medial patella luxation. So it luxates medially most of the time, like 70 to 80%. So in other words, the lateral patella luxation mainly occurs in medium to large breed dogs, and it's less common. So today's discussion mainly focus on the medial patella luxation for the same reason. So on most of the techniques and the way we do it, we will discuss, pay more attention to the medial patella luxation. That's the most common and the most common thing we come across in general practice. And the other thing is bilateral patella luxation. That means in both legs are affected in most cases. 50 to 60% of the time. It's not only one leg, both legs are affected. the pathophysiology of this condition. So as I mentioned before, it is a condition of this quadricep mechanism. This is a nice diagram of the textbooks of written by Johnson and Tobia. And so what it is considered as a developmental disorder. There are some abnormal of the skeletal, mainly the skeletal abnormalities of this the proximal femur. They are present at birth, even though in most dogs the patella is not luxated at birth. So when they develop, but they have these bony changes particularly in the proximal femur or femoral neck angle, and with development, so the distal femur and the proximal tibia develop bony changes, and main reason for that is this changing of the direction of this quadricep mechanism. So it's alignment of the quadricep mechanism. It's meant to be, this is a normal hind leg, where this quadricep mechanism is aligned with the axis of the leg, whereas this is a grade 4 high grade medial patella luxation, where the quadricep mechanism is more in the medially, not in the axis of the hind leg. So that's very important to understand. And so often they comes with these changes in the proximal femur, and also distal femur and the trochlea, and also proximal tibia or tibial tuberosity. So this tibial tuberosity get twisted to the side that luxates the patella. So this happens in opposite direction when it is lateral patella luxation. So the most common reason is it's more of a congenital or developmental, but rarely that could happen, from stifle surgery and trauma as well. The two diagram down below is actual leg of a CT image of an actual dog, and so on the left hand side, this picture shows a normal stifle, where the kneecap or patella nicely in the center, and the position of the tibial tuberosity. Whereas when you look at the image on this side, you see that bony changes there. The patella is here, and the tibial tuberosity pretty much like 90 degrees medially rotated. Now, patella luxation grades. So there are 4 grades of patella luxation: grade 1, grade 2, grade 3, and grade 4. So all the grades have very distinct features, as easy to remember. So the grade 1 means patella stays within the trochlear groove all the time, but we can manually luxate, particularly when the stifle is in extension. And the grade 2, patella stays in the stifle most of the time, but it can luxate spontaneously, particularly when the stifle is extension. When we examine in the clinical examination, the patella could luxate, or it could stay luxated when the stifle is extended, but when it's flexed, always it's come back to the normal position. And grade 3 luxations, patella stays out most of the time, but can be reduced manually, but we can forcefully put back in the trochlear groove, but as soon as we take our force out, it comes out. So basically these patella stays out all the time. And grade 4 patella luxation, patella stays out, but we cannot put back onto the normal position. So now we talk about medial patella luxation. We'll first talk about medial patella luxation, then we'll talk about the lateral petal luxation in the next slide. With this one, what we're going to talk about is mainly the clinical presentation, how we see them in real. The most patients start to show, most animals start to show their limb or lameness or clinical signs when they're puppies or young adults, usually initially presented as puppies and young adults. And grade 1 luxation is essentially an incidental finding because the kneecap do not luxate spontaneously, so they don't limp, and so it's never become a problem. And when we during clinical examination, we will be able to feel the patella and we can luxate it out. And as I said, usually these grade 1 luxations are not required any treatment. So that's common. And also with cats, and most cats, we can luxate the patella. It's considered as normal. So the grade 2 petal luxation, I have a nice video for it. So grade 2 petal luxation mean spontaneous luxation happens, but the patella stays in most of the time. And so they have a classic lameness called skipping lameness. They locked up their stifle and then hop from 3 legs and then walk like nothing happened. That's very unique with this particular condition. I have a little video to share. I'll do that next. The other important thing is with the grade 2 petal luxation, that could progress into grade 3 petal luxation if in some cases, if you let me the time. So there's a little risk of into a patella might stay out most of the time. Eventually, with the time, that could happen. And sometimes with the time, when the patella rides on the ridge of the trochlear groove that continues, that could cause cartilage erosions, and which could cause a little bit of ongoing lameness as well. So that we need to keep that in mind. But if in the young puppy with the skipping lameness, that's typical with grade 2. This is one of our nurses, my clinic, one of my nurses' dog, Nanda. It's skipping from the 3 legs and sometimes walk like normal, and eventually walks normally, like nothing happened. So these legs are not painful. That's important to note. Then the grade 3 and grade 4 luxation, usually they have severe bony deformity. So they are very disabled by the look of it. So the picture in here I took from Johnson Toby again, and they have a classic posture of crouch posture, and they're outward rotated, stifle, both stifles. That's classic as well. And usually the extensor mechanism is not efficient. So they're not good jumpers, and they can't jump. They crouch and they're very disabled. So it's easy to recognize it. So these images are from grade 4 luxation to show that this clinical appearance or presentation. They have quite deformity, quite severe deformities if it is not addressed when they're young, or can be very challenging to treat as well. But in general, the lower grade petal luxations are more common than higher grade petal luxation. So more commonly what we see is grade 2 and grade 3 luxation, particularly when we are treating the population. I'll briefly talk about the lateral patellar luxation and its clinical presentation. So they're pretty much the opposite of medial patellar luxation. The other thing is this is more commonly occurs in large breed dogs, as I mentioned before, and that's one difference. And the second thing is they are mostly bilateral as well, and that's another thing. And they are more functionally disabled, one, because they are large breed as well, and the other thing is they have a sort of a classic knock knee or genuvalgum posture. So the treatment is bit like principles are very similar to medial patellar luxation. We do all the procedures in opposite direction. So we'll talk about it later. Now, when you talk about I would like to talk about the clinical or physical examination a little bit more. So this patellar luxation condition is usually diagnosed clinically. So primarily through the physical examination, first examining them when they're walking, gait examination, or when they're standing, and then more importantly, palpate the patella, just like shown in this picture, and also during and trying to manipulate it in and out from the trochlear groove, particularly during the range of movements as well, when the stifle is extended as well as when the stifle is flexed, and tracking patella, how it behaves, and that gives a good understanding about the grade of the luxation as well. So this can be done in standing or on a lateral recumbency, more commonly done in standing. For radiographs, so more common, like when it is grade 2 patellar luxation without severe bony deformities, I think minimum radiographs should include lateral stifle and craniocaudal stifle and ventrodorsal view of the hips and lateral hips at least. And sometimes I tend to take, when I take VD hips, include the stifles as well at the same time. And this radiograph is not ideal. It needs to be a little bit further down to include the stifle more if you do that. Now try to keep both femurs parallel to each other, and keeping very straight is important too. If you are assessing the stifles at the same time, it's important to see this W shape of the femoral condyles, or on the other side, that shape is important to make sure that you have positioned the femur properly, and when we take the lateral views, it's good to include the hock joint as well, and then we can see all the way to the top, so that we can also check the tibial plateau angles and things like that, which may also be needed. Particularly if there is concurrent cruciate ligament injuries, things like that too. The other important thing is to get good lateral radiograph. I think having this femoral condyles, both condyles nicely overlap together, and also keeping the tibia parallel to the table. So then we can assess the torsion abnormalities, as well as when it's more important to measure tibial plateau angles, things like that too. And then it becomes a proper lateral radiograph. Otherwise, the position of the patella as well, and more accurately assessed when it is this way. So these two are just two X-rays I included just to show when it is when patella is luxated. When we take the X-ray, so the kneecap location where it is normally. The other thing we need to remember is, particularly the grade two luxations. When we take the X-rays, the patellas could be in normal position because it is dynamic. And let's need to remember that even though it's normal, it doesn't mean that there is no patella luxation. The other important thing is taking both legs. Always I would take both legs. Two additional views, not very commonly done, but particularly this extended stifle view is important to assess. There is another thing that in some dogs, the patellar position could be a little bit more too proximal from or just above the trochlear groove. It's called patella alta. And that condition can be diagnosed radiographically when if the stifle was extended fully. And the other view is the skyline view of the stifle to assess the depth of the trochlear. But usually these things are assessed when we do the surgery, when we do the arthrotomy, and you inspect the joint and understand it. That's usually or surgery. So the what we do with the surgery mainly is to get the alignment of the quadricep mechanism in a way that it's, the patella stabilized within the trochlear of the femur. So these are the things that we could do to help with it. The first one is trochleoplasty. That's mean the trochlear groove. If this groove is not deep enough, you need to have a adequate depth to keep the patella in. And that procedure is called trochleoplasty. We are going to talk about that soon, a little bit more. Not all the dogs need that, particularly low-grade patella luxation. Sometimes they have adequate groove. The other treatment is tibial tuberosity transposition. That is the key to success of this surgery, because that's the main thing that's done to get the quadricep alignment back onto the axis of the leg. So that's the critical one. That's the most important one. Almost every dog need that procedure to have a good long-term outcome. We will talk about that in detail for that reason, how to do properly, everything. The other things are soft tissue procedures. There are main two things we could do. One is medial mean that's for the medial patellar luxation. It's a lateral release for the lateral patellar luxation. That means releasing the tension, the tissue tension from the muscle fascia, the joint capsule, the luxated side, and allowing the patella to move back to the trochlear groove. That's called release. Release incision, but it's medial release for the medial patellar luxation, lateral release for the lateral patellar luxation. And the second soft tissue procedure is lateral retinacular imbrication for the medial patellar luxation and medial retinacular imbrication for the lateral patellar luxation. What that means is the side of the joint capsule need to be tightened up so that it doesn't let patella to luxate back again. So we'll talk about these two later on. The last thing is corrective osteotomies of particularly to the distal femur. That is required for mainly for the large breed dogs with more severe higher grade luxation. So they are rare. in common practice. So we will not talk about that much today, but that's more done on large breed dogs. Can be done for small breed dogs as well, particularly the grade 4 luxation with severe deformities. They need closing wedge or opening wedge prostatectomies and stabilizing with the bone plate to straighten up the leg or correct the angular deformity. Now, the objectives of this surgery are probably good to understand that as well. So what we're trying to achieve at the end. The first one is to improve the clinical sign. So that's why we don't do the surgery for grade 1, because there's nothing to improve. The limping should be improved. The lameness need to improve. The other thing is it reduces the progression of osteoarthritis as well, because particularly this abnormal movement of the patella and could cause cartilage erosions and then osteoarthritis. And also this reduces the risk of cranial cruciate ligament rupture as well. And one study showed about 20% of dogs have patella luxation untreated, get cruciate ligament rupture as well. I will briefly talk about surgical decision making. A few points about different things that to consider when we are making the decision to do surgery, when to do it, and how to do it. The first one is age. So this still image of X-ray of a mature dog with the proximal tibial growth plates intact. They're not fused yet. So that's an important consideration before when we do the tibial tuberosity transposition. It's recommended to wait at least 10 to 15 months or until this growth plate is closed before we do the tibial tuberosity transposition. So usually we need to wait until then. And the other thing is if the patella luxation is like grade 4 and severe luxation, it is recommended still to do the soft tissue procedures such as medial release and lateral retinacular imbrication, or vice versa for the lateral luxation to do earlier, and later on do the tibial tuberosity transposition when the growth plate is closed. Otherwise, that might worsen the bony deformity with time. The other thing a bit related to the age is that really old dogs with a low-grade patella luxation in particular, or if there is no much lameness, and I think they has to be managed conservatively. Any tendencies to not to do surgery. The other thing is size of the dog. So usually under 15 kilo dogs, we're talking, this is in relation to the tibial tuberosity transposition. We'll understand that a bit more when we actually talk about it. I would always use the tension band wire as well, as in addition to the 2 pins. When the dog weighs over 15 kilos. That's the important consideration. Otherwise, we could leave when we do the tibial tuberosity transposition, we can leave the distal tibial attachment or periosteal attachment intact and just use 2 pins only. So that's for small dogs. The other thing is it's good to always check for concurrent cruciate ligament injury as well. If the drawer sign is present, or when you do the arthrotomy, you inspect the cruciate ligament. If there is a cruciate ligament rupture, always should address that. Otherwise, they're not going to do well. Then there is bilateral luxation. My tendency to treat the worst leg first and then to the other one. And I know some vets do both legs together as well, but that associate with a higher rate of post-op complication. Yeah, so we talk about this, if whether there is any severe deformities, particularly distal femoral varus or function, then they need this corrective osteoporosis as well. And also good to understand that if the surgery didn't go well with just the other procedures, we know that it needs to be more, or if there is any different place that those things can be done as well. We'll talk about the grade in terms of how grades with decision making as well, because this diagram is nice one to understand how the bone deformity occurs, how severe the bone deformities are along with the grades. So this is the normal stifle. When you look at here, this is the axial view. So the black line is the femur, and the green line is the tibia, proximal tibia. That's the proximal tibial tuberosity, and this probably red one is the patella. So the normal dog, there's a nice trochlear groove, at least 50% of the patella inside, and the tibial tuberosity is aligned straight with the in the midline. Now, when you go to grade 1, there's a little deviation of the tibial tuberosity, and then that deviation get more and more, and it might go all the way like up to 90 degrees of deviation or rotation immediately. This is the medial luxation, happen another way around, or the lateral luxation. That's how this deformity and how severe the deformity could be along with the grade. So that dictates how much transposition, how much tibial tuberosity should be moved back to bring back this cohesive mechanism to the alignment, to the axis of the leg. So when the grades get more, we need more transposition. And also, depth of the trochlear groove is also varies, it gets shallower and shallower. So it needs that need to be addressed as well when the grades get higher. But some grade 2s, it doesn't need trochlear groove deepening. So this is just to briefly go through some of the equipment, particularly for those who wanting to start this procedure, start doing it in their practice. Just a couple of points mainly. So that we need a saw. I think this oscillating saw is much more easier to have. Easier to use, and it does the job quite quickly and more accurately. It's far more superior than using a handsaw or steel tool to cut the bone, particularly when you do the trochlear groove deepening, or when tibial tuberosity osteotomy. The oscillating saw is very useful. It makes a big difference. It takes only very little time and effort to do an accurate cut. Okay? And the other thing is the battery-driven, pin driver, or use a drill as well to put those gear wires and pins with Jacob chuck. This is much more easier to use. It's good to have that. Invest that. Buy one of those. I think when starting this procedure, that saves a lot of time. And the other things are small pins and gear wires and wire twister, and you need a pin cutter, and you need to have a periosteal elevator, with meniscal probes and retractor, whole retractor type thing to inspect the menisci and the cruciate ligaments, and good to have a couple of GLP retractors as well. All right. So now we'll talk about this actual surgery. I would position them usually on dorsal recumbency when you're having a cradle or V-shaped table is used. So once positioned in the dorsal recumbency, the affected lip aseptically prepared and draped, you get the whole leg out. And the first step is arthrotomy, usually cranial lateral approach. That's the standard cranial lateral stifle arthrotomy, and then examine the joint, particularly inspect the cruciate ligament. So this image shows not the cruciate ligament, and that's an insert for same retractor, the Yelp retractor helping to visualize it. And also the other things are I need to assess the patella. I would inspect the patella as well. It's underneath, and then the patella groove, where the patella sit when the staphyl is extended is important as well. Make sure it is not too far proximal. Make sure that's in the trochlear groove, and then the depth of the trochlear groove is evaluated as well, and it need to have a reasonable depth, ideally 50% of the height of the patella. It's through the experience. Usually measurements are not taken, just inspect and see whether that groove is adequate. And the other thing to note is whether there is any. So this image shows cartilage erosion. So the patella riding on the ridge of the trochlear groove continuously, and has caused cartilage erosion type thing can be noted, and that confirms that's causing problems. All right, now we'll talk about fascial release incision. So it's called medial release as well for the medial patella luxation, and it's obviously the other way around for the lateral patella luxation. So once you joint inspected through this, so this is it's not the most attractive diagram, but it shows the basics. So this is the lateral side of the leg, and this is the medial side of the leg. So dogs have a medial patella luxation, and the lateral arthrotomy incision in here, and patella in here, and then the patella tendon down below. And so this is the medial release incision on the opposite side. That's where the patella was luxated. So that releases the patella to come back to its ideal axis. So usually the main thing is need to main anatomical structure to take care of is the patella tendon. It's very important not to damage it, not to cut it. Always should identify it and make sure that you make this incision at least 2-3 millimeters lateral medially to the patella tendon. Usually the incision starts a couple of millimeters proximal to the tibial attachment and then goes all the way back until that tension is released. Until that tension is released. So usually maybe a little bit more proximal from the level of patella. And this incision go as deep as to the muscle, not only the muscle fascia, but also to the joint capsule as well. And usually leave it open. No need to put sutures. Usually leave it open. Now the trochleoplastic. So there are few techniques doing this. So this wedge recession trochleoplasty. That's the most commonly performed procedure as far as I know, and that's what I do as well. So what that's we need a. I think I would prefer a oscillating saw or a handsaw, but can use a handsaw as well. And removing a wedge shape of cartilage and subchondral bone, and pretty much cutting a wedge, or maybe a slightly medial to the edge of the central axial. And then once you remove the wedge, you take additional ostectomy, remove a tiny bit more bone from both sides, or you can sometimes use bone from one side more laterally and make it and then putting the wedge back in, and to allow at least 50% of the patella to sit inside the groove. In this procedure is preferred because it preserves the articular cartilage, whereas the abrasion arthroplasty, where you use a ronger and remove cartilage and underlying subchondral bone to create a growth. Eventually, it transforms into a fibrocartilage with healing, and but as it removes articular cartilage, so it's not preferred. So if you can perform this wedge, or you can block recession arthroplasty, that's preferred. Now, tibial tuberosity transposition. So this is the most effective long-term treatment. If you didn't perform this often, these patella surgery fails on the track. So it's very important to perform this properly to get this quadricep mechanism back into the alignment. So the one big thing is, again, I use this oscillating saw to make the cut. We'll talk about osteotomy a bit more to understand or learn how to do it, and what can go wrong in that. Right. So the first, so this image here to show how much bone you can remove. So the biggest commonest mistake or commonest complication associated with this is because of taking too small bone paste, or too small osteotomy. So when we put pins in, that bone fragment can get fragmented. Also could have failures, like an avulsion of tuberosity, implant failures, and as well when this bone fragment bone is too small, your osteotomy is too small. So I'm going to show you how big you can go. We don't have to go that big, but in maximum. So in general, what I will do is each and every door, when I do the procedure, feel of the most cranial aspect of the tibial tuberosity, and the most caudal aspect of the femur. Sorry, the tibial condyle, or back of the tibia, and that's the widest part of the bone. And about 40%, and the cranial 40% is generally in the safe zone. So it doesn't, it's about in that area. So there's a rough idea like that. The other biggest landmark is extensor groove. That's easily palpable, readily palpable in each and every door. So just cranial to that, there is a little notch called a tubercle of Gerdy, or you can feel a little knot, or at least you feel that. In some doors, it's not very obvious. Tubercle of Gerdy, and that's where the joint ends. That's the cranial border of the joint, or that's where the cranial cruciate ligament is as well. So always we need to osteotomy need to be cranial to that point. So we have that, and also distally as well. People tuberosity flushes with the shark, the diaphyses of the tibia. When that tibial tuberosity, that where it ends, so we can remove that up to that level. So that osteotomy lies in that zone, but it is usually about 3-4 centimeters, like proximal to the tibial tuberosity. The patella tendon attachment. The patella tendon attaches here, 4 centimeters. Poorly, that's where you do the incision. The osteotomy. But we have a large rhythm that is good to understand, or so need to make sure that not to go too far. The second thing is when we cut the bone, when you perform the osteotomy, it's important to make sure that the tibia is parallel to the table and hold the oscillating saw blade perpendicular to the table as well in that plane. So it cuts a even cut. When we do this surgery in small dogs less than 15 kilos, usually the osteotomy is performed incompletely, like distally leave the periosteum intact, and then we'll use a periosteal elevator, or we might use a sharp tool to move the tibial tuberosity in medial patella luxation laterally, and see slowly move it, and to a level that's aligned with the axis of the tibia, or to get the quadriceps alignment. Another thing to do is like to facilitate, it's very sometimes be difficult to understand whether I have moved that enough, or whether I have lateralized enough. And one thing that I would do is putting a small pin, so we can move it and put a small pin on the osteotomy side, so that it won't fall back, and then you can assess the leg, palpate it, and move it in the range of movement, and see whether the amount of correction is adequate. And then you put pins into the tibial tuberosity, which we will discuss next. How to put the pins in. But if there is a patella alta, or particularly in a large breed dogs, if you want to move the tibial tuberosity distally as well, to bring the patella back onto the trochlea, and then you need to make the cut. Or with a very severe patella luxation, grade 4, and if you need to move the patella tuberosity further, then you might need to complete it. Most of the time, you can leave the distal attachment. Here we'll talk about the pin trajectory, and how to put the tension band wire, and so the direction of the pin. What is the best way to put pins? So when we this image shows a distally intact periosteum, and the osteotomy is done nicely, and the pin direction, angle of the pin, is very important. It's ideal to get this angle perpendicular to the weight-bearing axis of the tibia. Try to get it perpendicular, but there's a reasonable room for error, like up to 20 degrees from either direction. But it's clinical if you try to get it perpendicular. Look at the shape of the leg, trying to get, and that as we try to do. The other, if it's too far, if the directions is a bit more deviated from this, that could be associated with congregation or implant failure. The other thing is when we exit the pin, so it goes perpendicular to the long axis of the tibia, and also it's good to project the pins, particularly if you do the medial patella luxation, if you transfer the tuberosity laterally, angle the pins medially, so the pins stays within the bone tissues. So in this way, it shows it try to exit on the medial side. With, and the other thing is two pins are always recommended because it associated with less complications. One pin is associated with post-operative complications. So always two pins are preferred. The other thing is tension band wire. When we use for large dogs, active dogs, if you accidentally cut the distal attachment, you always need a tension band wire, and it's best to include not to go just through the cortex, need to go a bit further in and go through the medulla as well. So it includes 4 cortices, so the strength is a bit. The last procedure is retinacular imbrication. That means it's pretty much the closing of your arthrotomy side, the muscle fascia and the joint capsule. That's called retinaculum. And imbrication means once you move the patella laterally, so there is a loose joint capsule and there's loose tissue on that side. So the idea behind this is to tighten up that tissue so that it gives a further support to stabilize the patella in the correct position. So this usually done it's usually done with this particular suture technique. So it's called vest over pant sutures. So normally with a small dog, approximately 3 to 4 millimeter from the cuttage. So always when we do this arthrotomy as well, it's very important to identify the patella tendon and the patella and leave a little bit of a room for the sutures as well on that end. Should not go all the way down to the tendon and leave a little bit of tissue all the time. So it's easier for you to when closing the wound, placing the sutures. So sutures usually placed approximately 3 to 4 millimeters, away from the cuttage. If you do that in both sides, it gets about 6 to 8 millimeters in. So or the other alternative is to trim that extra tissues. I normally trim that from not from the patella side, but from the other side, and then suture with the mattress, which is a cruciate or mattress sutures, so that it won't fall apart. Otherwise, without resecting, you can just use the vest or pant sutures and suture it. So usually use monofilament absorbable sutures, very small dog, 0 or something. If it's a bit more active or bigger dog, use the 0 sutures. The other thing is sometimes you have to cut some of the joint capsule. When it is too loose, it's very hard to get it together. So that's called partial capsulectomy. That might need happen as well. What if there is concurrent cruciate ligament rupture as well in a small breed dog? It's very simple to address at the same time. We could do a lateral suture just like we do for check-head there at the same time. The other thing need to understand is sometimes very low grade patella luxation might be grade 1 or grade 2. those dogs, when they rupture the cruciate ligament, the patella luxation become a little bit more obvious, because of the lack of this, because of the instability of the cruciate as well. And so those ones, when we examine, feel like patella luxate like more severely, but once you correct with the cruciate, the extracapsular suture, that usually gets stabilized. So it's important to understand or ask a question from yourself, see what came first, whether the dog had any limping or lameness in the past. If the dog did not have any skipping lameness or limping or gait abnormalities in the past, and now we have an obvious patella luxation on the clinical exam, so there could be like a very low grade luxation, sometimes even no need to transfer the tibial tuberosity, even just need the extracardiac surgery. But we could imbricate the joint capsule laterally to help stabilize it, and I found that in many cases that's adequate. But if both are present, we could perform because there is enough. So these the holes to pass the lateral suture are done more quarterly than the osteotomy side. Right. The post-operative care and the outcome, generally, almost all the time, I would take immediate post-operative X-rays, even though you went, then at least you understand, even though you wouldn't revise the procedure on the same time, but I would at least understand what we did, and so that helped you to talk to the owner and explain things, or things didn't go well, then there is something to look back and see how it was when you do the surgery. Analgesia is important. So normally NSAIDs for about 1 to 2 weeks, and I would give opioids like patch or something like that for 3 days, and then confine activities for about 8 weeks until that osteotomy healed. So it can take X-rays in that mark, like particularly if they're doing well, before we let do normal activities. Normally those pins left in there unless it causes a problem. Expected outcome, in generally they put weight and walk amazingly quickly, like in most, particularly with the low grade luxations. Within a week they walk well, seems comfortable with the leg. That happens within a week usually, maximum within 2 weeks. But there can have odd cases that everyone seen that, like I talk to more experienced surgeons, and sometimes we get an odd case that don't do well and hard to understand why. Probably something to do with their muscle atrophy, or the adaptation to the new axis, maybe that kind of thing could happen sometimes. But I think for those cases, if they're not doing well, always I would redo the radiographs and trying to understand why. Is there any underlying cause? If there's nothing, then probably I would put more effort into the rehabilitation and physiotherapy side. Generally, the prognosis is good, particularly with the grade 3, grade 2 patella luxation. The outcome is probably good to excellent. All right, now I'm going to talk briefly about possible complications and what to do as well. Recurrence of luxation is a common issue. That's when we do the procedure, but these then again patella luxate after a little while. Often it's because of the technique. And we haven't probably transposed the tibial tuberosity adequately, or laterally is not lateral enough, or we have used just the soft tissue procedures only. So always need to revise the technique and redo it, luxating with radiographs and try to understand it, and then we do the surgery. And there are had some cases that had some breakdown of that imbrication surgery as well. That could happen too if it is need to be repaired. The other common complication is implants related. One is implant failures, where these pins can bend, and also here in this X-ray shows that the hinge band has come off the tibial attachment. Probably is because it's only going through the cortex. It's not going deep enough, and that might have caused failure. And adequate size of the using adequate size of the tension band wire is important, and pin angles important, as we discussed before, and probably the post-operative care as well, and avoiding high impact activities, jumping, that kind of activities until the hospital is healed is important. The other possibility is implant migration. Sometimes these little pins, you put it now up a couple of months or sometimes years later, sometimes you find them migrating. So they might go under the skin. Sometimes might go to a really odd location, like far away from the actual surgery site. That could happen, but very easy to find the X-rays, and then making a small incision and then the other possibility is overcorrection. Sometimes we think we did it, and then sometimes it's overcorrected. So medial petal luxation, once you treat it, it becomes a lateral petal luxation. And then that needs a corrective surgery, sometimes of releasing from the lateral side, allowing patella to come back, and a bit of imbrication enough. Sometimes you need to redo the osteotomy and bring the tuberosity a little bit more medially if needed. Infection. What if you get a deep infection in the bone? Normally, the bones can heal through the infection. So usual approach is to, if everything else looks fine, but just the bone got infected, then usually they kept on antibiotics, ideally after culture and BVSc and selecting appropriate antibiotics. Otherwise, cefalexin or amoxiclav, something like that, to cover staphylococcus intermedius mainly. That's the most common one, and like a broad-spectrum antibiotic for until the bones healed, and then removing the implants is usually the treatment. Tibial tuberosity avulsion can happen, then need to be reattached, particularly what we do with the implants and the technique. Trochlear wedge displacement, sometimes trochlear wedge can be displaced and need to be corrected and addressed. And the patellar tendon rupture is kind of a little disaster if it happens. So that's the main structure that I would be careful when doing this surgery throughout. There is no other important structures in the area when we do the dissections and everything. I think if you accidentally cut the patellar tendon, that's a difficult and challenging one to repair, and needs a lot of care with the recovery. So if it happens, it need to be repaired, and then the limb need to be immobilized until the tendons heals. All right, thank you very much, and that's it.
Thank you, Dr. Bhagya, for your wonderful presentation. Now it's the time for the Q&A session. If you have any question, you can direct to Dr. Bhagya.
Yeah, thank you very much, Bhagya. I'm Ganandika. So it's very highly
Hello, Randika.
interesting, highly impressive relaxation from because we're also doing some surgeries for this in our hospitals. But today we got a real idea, what's the principle behind it and what are the grades of relaxation. And so very good. And I have a little question, Bhagya, actually. After the surgery, if there's any special, exercise, I mean physiotherapy or procedure, so how we adapt the conservative care of the, patient, because we sometimes see even we are doing the surgery after a lot of efforts, I mean, due to crooked movements, it can relapse sometimes,
Yes.
and how do you manage that after the surgery actually? Yeah. How do you advise the client? Yeah.
No, normally what I would do is, I mean, because they wait there within short time, like within a week or so, usually doesn't need like additional specific physiotherapy other than, if they can take little slow walks on a leash. I mean, it's probably not practical in Sri Lanka, but you could do it in the backyard maybe, like taking on a leash and walking about 5 minutes twice daily, and maybe increase that weekly, that sort of a thing, like, to improve use of that leg. And that's pretty much. And also the first week or so could do this, cold therapy and heat therapy and a range of movements and things like that. But I found almost all the time that's probably not required. But could be helpful. Is that what you ask, or is that something else?
But yeah, I mean, how do you manage the patient after that, after surgical care actually? Yeah, how do you advise
Yeah,
the client?
usually I would confine the activities and keep like, restricted for about 8 weeks. And then we can gradually, the first wait about 2 weeks or so before we take walks and things like that. During that first 2 weeks, it's only going out to do toilets and then stay inside, that sort of lifestyle. And after that, it's good to walk around a little bit slowly and gradually, then increase it. So in about 6 weeks or so, they walk normally in most cases, like particularly low-grade luxation.
And on the other hand, Dr. Bhagya, actually, if you have bilateral luxations, I mean, you do to attempt the surgery at the same time, or just do one side first and then later on we'll attempt the second one. Is it? How do you advise?
Yeah, it's a good question. Like, some vets do both legs together, and some. But my preference is to do the bad leg first, and then wait it until it recovers from it, and then do the other leg. The reason is then the complications are low. Sometimes you get an infection or something, you get a complication, and then you have two legs and they struggle a lot to walk and things like that. The other thing is that if the dog doing well from one leg, once you do it and correct it, then it gives a good assurance to do the second one too.
Yeah, thank you very much, Dr. Bhagya.
And also you can send your questions in the chat book. You can type your question in the chat, and also you can raise your hand, or you can directly ask the question from Dr. Bhagya.
Okay, what is the suture material you use actually, when you're suturing, inside tissues and the, to get this TDS? Okay.
Yeah, normally TDS is not like an absorbable.
Non-absorbable ones, right?
Yeah, sorry,
Okay.
absorbable.
Absorbable ones. Okay,
Yeah.
okay.
So even the imbrication sutures are absorbable like PDS.
Okay.
Dr. Bhagya, I have a question.
Yes.
What are the analgesic drugs can be used?
Yes. So so NSAID, like you could use a carprofen or meloxicam. I'm not sure that's available there. Carprofen, oh, you could use remedial type thing. So I would use a NSAID and continuously, like at least a week from the day of surgery, give an injection on the day of surgery, and then continue with tablets. And then then an opioid. It's good to use an opioid, like we have a fentanyl patches. I'm not sure whether that's available. And last time when I discussed with one, I think said that we don't have that in Sri Lanka, like fentanyl patches. Fentanyl is an opioid, and you can put like a little. It's like a sticker. It's a transdermal patch, and you clip the hair and put that patch on it, and then it gives pain relief through the skin. Otherwise, we need to use something like injectable opioid, like the morphine or methadone or buprenorphine or something like that, along with the NSAID. So particularly for the first, maybe 2 or 3 days, it's important to have a stronger pain relief as well. So generally, so that's what's done here. Do you have any opioids in there now, or?
Yeah, we have in the market. Sometimes it's very difficult to get them back. I mean, like pethidine and those, and the meloxicam actually we have, and ketophon we have.
Yes.
And remedial tablets, yeah, morphine, yeah, we have, yeah.
Yeah, I think morphine can be used. It's really
okay.
useful for the first immediate burst of pain.
Yeah.
That gives a really good pain relief.
Okay, thank you, Dr. Bhagya.
Okay, thank you very much.
Yes, now, I think there are no any question in the chat box also. I think now we can wind up the session since there are no any more questions. So I thank Dr. Bhagya for his very informative speech on behalf of the SLVA, and also I would like to thank all the participants who participated for this session today. I think Dr. Sugat is there. Hello, Dr. Sorry, Dr.
Yes.
Sugat, because I thought not online. That's why I said. Dr. Sugat, I would like to invite you to do the vote of thanks on behalf of SLVA.
Thank you very much, Dr. Janaka Amrakon, Vice President, Sri Lanka Veterinary Association. Dear President and our resource person, Dr. Bhagya, and all the members in Sri Lanka Veterinary Association. On behalf of 73rd Executive Committee of Sri Lanka Veterinary Association, I would like to extend our sincere gratitude to our resource person, Dr. Bhagya, who accepted our invitation without any disturbance to the others. You gave the best webinar today, and also you did another webinar at the beginning of our webinar series. That one also a very nice and very good one. Thank you very much, Dr. Bhagya. As well as I believe the knowledge you have shared will help immensely to improve the knowledge of veterinarian in the country. And I also I would like to thank Dr. Janaka Amrakon for your comparing today. Thank you very much, Dr. Janaka. And also I would like to thank our president and the participants from the different part of the country, as well as another few veterinarian will participate from the overseas from YouTube channel and Facebook. Thank you very much for everything. Thank you.
Thank you, Dr. Sugat. Thank you for joining all. And now we are going to wind up the session. Thank you.
Thank you.
Thank you, Bhagya. All the best. Yeah.